Welcome everyone to Navigating Client Capacity Issues. We've got a great webinar for you and we will get started now. All righty, so starting off with our dear disclaimer. You all have seen this before, but we do this every time. This event was made possible from a grant awarded from the Office of Victims of Crime through the DOJ. The opinions, findings, conclusions, and recommendations made throughout this event are those of the contributor and do not necessarily represent the official position or policies of the US DOJ. All right, a couple housekeeping items. We do have a larger group for this webinar, so just make sure that you are properly muted so we prevent any feedback coming through as we walk through these slides. Feel free to use the chat function at the bottom of your screen. I'll be monitoring the chat today. So if you have any questions or issues that arise during this time, please feel free to use that. And we will just make sure we get your questions answered. I think everyone is looking pretty good, but if you need to rename your Zoom square, please make sure that it displays the name that you would like to be referred to as. If you hover over your little Zoom box, there should be 3 little dots that appear in the top right-hand corner. You can click rename, and you should be able to put your first and last name in there as well. You can also feel free to use the raise hand feature to verbally address a comment or question. We won't be using breakout rooms today, so no worries about that, but we will be having polls. I will be launching those towards the beginning and then the end of the slides. You will get instructions on your screen. I'm sure you all are familiar with that. And then, of course, if you have any technical issues or questions, please feel free to contact me. The best way to reach me is actually through a direct message in Zoom today. I'll be with you throughout the whole session. So if you have any questions, please feel free to reach out. My name is Anna Cash. I'm the Training and Technical Assistance Specialist with NCAL. And I will turn it over to our 3 wonderful presenters and we will dive right into our content.
Awesome. Thanks so much, everyone, for having us. I'm Elizabeth Bloemen. I'm a geriatric fellow, soon to be a geriatrician at the University of Colorado. I also do a fair amount of elder abuse research, primarily focused in injury patterns, and then the healthcare response to physical abuse, sexual abuse, and neglect. I am part of a team here at University of Colorado called the VESPA service for Vulnerable Elder Services Protection and Advocacy Team. We serve University Hospital and Denver Health Hospital as an elder abuse consult service. So we see patients on the inpatient setting and then at our Denver Health site at the outpatient setting when there's concerns for elder abuse and neglect, and provide a geriatrician, forensic nursing, and other support, specialized social work, civil attorneys as needed to those patients to help them navigate this system. So that's a little bit about us and our team, and I have 2 of our wonderful other team members here as well today. Thank you for having us. Sarah Cox.
Hi, everyone. I am the social worker on the VESPA team and work primarily at University Hospital.
Hey, everybody. I'm Sarah Tietz. I'm a geriatrician at UC Health or University of Colorado Hospital here in Denver.
We'll go to our learning objectives. So today we would like to just chat a little bit about capacity, but doing so requires, I think, a fair amount of discussion about what's cognitive impairment versus capacity versus competency. How do we assess for these different things? How do we as clinicians diagnose them? And how do we work together to get patients, and I'm sorry, I will always use patients because I'm a doctor and that's how my brain works. So patients, clients, older adults, what they need to be safer and be living their lives as healthily as possible. So hopefully this will be useful. Again, please feel free to interrupt us if there's anything you'd like to add or have questions about throughout the presentation. Sarah Cox.
Yeah, so I think we're going to start with a poll. We'd like to start by seeing how comfortable everyone here is with capacity and capacity assessments. That means conducting them, interpreting them, also when to ask for a capacity assessment.
All right. So before we do this poll, just because there's a number of you that we don't recognize, if you could just chat your name and your agency or organization you represent, or just a general background on the type of work you do. So for example, APS, law enforcement, et cetera, broad description is fine. And then we will launch this poll just to get to know each other a little bit better. And we can do that simultaneously as well. So I'm going to launch this poll, and please feel free to introduce yourself in the chat as well. I already see those coming in. Thank you so much. Once that poll is done and we've got enough responses, I will share out the anonymous results. Right, we're at about 75 folks, 75% of folks answering the poll. If we could just get the last couple of you. No worries also if you don't want to participate in this poll. All right. I'm going to be closing the poll and sharing the results. You'll be able to see those on your screen right now.
I mean, definitely all over the board. So I think we're really looking forward to not just questions, but comments from everybody involved today. Okay. So why does capacity matter? Certainly it affects the resources available. I think hospitals obviously need to know for medical decision-making, discharge decision-making. Outside agencies that may request that information are other medical providers, home health agencies, adult protective services, law enforcement. I've had them ask me. Certainly the court, when there's a pursuit for conservatorship or guardianship. In the work that my team does around concerns of elder maltreatment, being able to tell APS when making a referral that a patient does not have decisional capacity, for example, around medical decision-making, may sway them to screen in this case. I think it adds to their vulnerability. And APS is screening a case based on a patient's vulnerability. And when someone is considered to have capacity, for example, to make their own decisions, then, you know, we really must ultimately respect their decision-making. We can make suggestions around like a safe discharge, but it is up to the individual. And when they don't, there needs to be an effort to continue to try to understand their wishes, the history of their choices, the safety of others. Are they doing something that's putting their neighbors in danger? That's something that needs to be considered as well when deciding if that is something that we can continue to allow. And then who needs to get involved? Sometimes it's not just about the patient, but about the family and specifically the caregivers. What are they able to continue to sustain in terms of caring for them? So weighing in everybody's, weighing in everybody's kind of the involvement in this situation. So.
All right, so I know that there's a wide range of experience here with capacity, and I think the poll showed that. So we'll start with really basic, hopefully get to some information that even people who are more familiar, it's helpful to you, but feel free to ask questions in the chat or to unmute if you've got other questions that you think we could speak to that maybe would be more helpful. So first wanted to just talk about the difference between cognitive impairment, what it means to not have capacity, and then the difference between capacity and competency. So cognitive impairment is really just when a person has impairments in their ability to think, remember, use judgment, and it's greater than expected for age. So this could be anything from somebody with mild cognitive impairment to somebody with dementia, somebody with a traumatic brain injury. We'll talk about different things that can impact your cognitive impairment, or somebody with intellectual disability. Just because somebody has cognitive impairment doesn't mean that they lack capacity. And so we use different tools to assess cognitive impairment than we do to assess capacity. And we'll talk some about that today. So capacity is really, can somebody understand the risks and benefits and the alternatives to something? And so we often think about this in the medical field in terms of a treatment, a surgery, an intervention. So are they able to choose to go on dialysis or not go on dialysis, or have a surgery, or to do chemotherapy instead of the surgery? But we also think about capacity in terms of different life choices. So we think about it in terms of people's financial decision-making capacity, or in their ability to decide on discharge from the hospital, discharge home, to a nursing home, to rehab. And then we also assess people's capacity to decide to continue to live in the community. And I think those are different decisions that require a little bit different approaches. So we'll talk about some of the tools that we can use for those different decisions. A capacity is also time and decision specific. And so that means that we assess capacity in this moment. Medical providers assess capacity. There's a wide range of medical providers that can and can't, or that can and feel comfortable doing capacity. But capacity is really decision by decision. And so you can have capacity to do something like assign a medical power of attorney, but maybe you don't have capacity to decide on a complex medical decision, such as a brain surgery. And so we try to assess capacity on each decision in that moment. Capacity can wax and wane. So if somebody is intoxicated on alcohol, they may not have capacity in that moment, but it may improve. If somebody has a bad infection and they're confused in the hospital, they may not have capacity to make some decisions, and then that can improve. And so capacity can come and go, can wax and wane. And so really you should be assessing capacity at the time the decision needs to be made, and it should be regarding that specific decision. When we think about capacity, we also think about risk involved in those decisions. And so the risk involved with making a decision around who's your decision maker, your medical power of attorney, is a lot lower than the risk involved in choosing where to discharge. And that's a lot lower than choosing, like, I want to forego a surgery that could potentially save my life. And so we think about both the person's ability to make decisions, but we also weigh the risk of that decision when we're assessing capacity. And then competency is really determined by a court. And so our capacity assessments help impact the competency decision based on the court. But competency is thought to be chronic, to be stable, and that it's something that we expect to continue throughout someone's life. And so somebody who lacks capacity in the moment doesn't mean that they would lack competency long-term. Competency is a much higher bar to say that somebody lacks that. And so that's really made by courts, and then medical providers often go and testify, but ultimately the court decides on competency, not medical providers. So I will hand it off to Dr. Bloemen to talk a little bit about cognitive impairment and some of the tools we use for screening for it.
Yeah, so when we start to think about cognitive impairment, I think most people that work in this sphere are pretty familiar with our basic screening tools. So the three that we see probably the most often are the mini mental status exam, the Montreal Cognitive Assessment, or the MoCA, and then the SLUMS, the St. Louis Assessment. We'll also talk a little bit about a clock drawing in a few minutes, because I think that's really helpful. The screening tools can really be done by a lot of different clinicians. Some clinics have a medical assistant who does it. Sometimes the physicians do it themselves, but there's a wide range of who's qualified to do just the screening tool. But when we're talking about a diagnosis of cognitive impairment, that really should be coming from a provider, and it's usually a PCP or a geriatrician. Psychiatry and neurology also often give these diagnoses, but really the screening tool is separate from the diagnosis, which involves a lot more in terms of history, screening for other things that could be contributing, and really examining the patient to make sure you're getting the right diagnosis. So we'll talk a little bit about each of these tools. So the mini mental state exam is the one that's been around probably the longest. The main thing that this test examines is really a lot of orientation and attention. And so it's less helpful for that kind of executive dysfunction, visuospatial reasoning, things earlier on. It's also less helpful for our highly educated population. They can often have pretty significant impairment and do very well on this test. And so it's kind of fallen out of favor. It's still like free and in the public domain. And so a lot of people still use it, but it's definitely more helpful for people with moderate or severe impairment or lower education level. This one has really been validated, though, again, as with most of our tools, in like, I would say mainstream Western culture and in English. And so there's also limitations if you have patients coming from other cultural contexts or other language backgrounds and things when you're doing these screening tools. And then this is the MoCA. This is probably now has become more the standard in the field, although they recently made it so you have to pay for it. So some people have switched back to other versions. This is my preferred tool. I think I've memorized it. So hopefully my dementia diagnosis will be put off for a couple of years because I've memorized a couple versions of the MoCA here. But I like this tool because it tests more domains. And my preference clinically is to give it myself. My medical assistant certainly can, but seeing how patients do this is often very helpful to us as clinicians and how they problem solve through it. It starts with that visual, spatial, and executive reasoning, which is helpful. There's also attention paid to the attention domains and abstraction domains. And the MoCA has been pretty well studied. So in one study, they found that a MoCA of 22, the probability that you'll have capacity, the correlation is 75%. So 75% of people with a MoCA of 22 still have capacity to make pretty much all decisions. When your MoCA drops to 15, the likelihood that you have capacity drops to about 24%. Again, this isn't diagnostic, it just correlates, but it can be a good screener. So if I hear of someone who has a MoCA of 6, I'm going to approach that capacity evaluation very differently than if a MoCA of 28. And so just to kind of keep that in the back of our minds. And then the SLUMS is also one of the publicly available tools. It's kind of like the middle of the road between the MMSC and the MoCA. It is the preferred for veterans and through the VA system. I also do work at the VA, so if anyone has questions about that system, I'm happy to answer that. I know that can be kind of a black box for some people. And so this tool is kind of, again, it's a little bit of middle of the road. I think it's a little more sophisticated than the MMSC, and it's free. So a lot of people are using this one now. And then this one is a clock drawing, which really is very simple to administer. You just ask someone to draw a clock and you tell them what time to put in. So it's very easy to do, doesn't require a lot of training, but it's exceptionally effective. So it can the sensitivity for diagnosing cognitive impairment is 82%, and the specificity is 75%. This is actually an example from one of our clinic patients in the last couple of weeks from a different provider. But you can see it takes a lot of planning, a lot of visual spatial reasoning for people to do. So if you're pressed for time, or if you're just trying to get like a sense of generally how is this person doing, if they have a bad clock drawing, that's a really helpful thing to pass along to their providers or other service providers, because it can be really, really helpful. And it's very quick to do. And so I like that one as well for our evaluation tools. Dr. Tietz.
All right. So I wanted to talk about how to assess capacity and the components that you need for capacity. The other thing I wanted to mention in terms of who can assess capacity. So technically all medical providers can assess capacity. That doesn't mean all are specifically trained in capacity assessment. And that doesn't mean that all feel comfortable assessing capacity. And so there's a wide range. A lot of it's cultural too, of who's trained in which location. So in some states, social work colleagues are kind of primary people that assess capacity. In some places, it's almost only psychologists. In other places, it's often primary care. And some of that has to do with the culture. Some of that has to do with resources. When you're in rural Colorado, probably the only person available is going to be the primary care physician. And so they might be the expert in the area on assessing capacity. And it's really about experience and training of whether people feel comfortable. Some maybe have had very little experience, and so they might not feel comfortable at all. So just wanted to talk about that. Technically, all medical providers can, but that doesn't mean that they should or that they feel comfortable doing it. So this is kind of the basics of what's required for somebody to have capacity. This is based off the Applebaum model. So Applebaum was kind of the first that described capacity, and it really says that you need these 4 components. So the first and kind of easiest bar is people need to be able to express a choice, and that choice needs to be pretty consistent. People are allowed to change their mind, but they should have kind of a reason that their mind changed and be able to explain that to you. Otherwise, the choice should be relatively consistent over time. So that's number 1, express a choice. Number 2 is people should be able to understand the situation. So they should be able to say, I have a brain tumor, and I know that the options for me would be to either have a surgery, to do nothing and go on hospice, or to do chemotherapy. And those are my 3 options. And I'm able to kind of tell you risks and benefits of each. So people need to be able to understand the basic situation. Sometimes people haven't been given a lot of information about a problem. And so it's also important to say, can I explain to you about this first, and then see if you can kind of repeat it back to me. So that's just basically understanding where you're at. And then reasoning is really, do you understand how to choose between those different things? What are the risks and benefits of this decision? And why are you making the decision that you are? Are you able to kind of link your own values, your own goals to the decision you're making? Or does your decision seem kind of random and not at all correlated to what's important to you? And so really being able to understand the reasoning behind it. And then appreciation is kind of the highest bar. And so appreciation is, can somebody appreciate how that decision impacts them personally, and also how their own limitations impact the decision that they're making? And so I think about this a lot with dementia, is that people might tell me, oh, I totally am fine. I want to go home. I understand. I'll just go home and take care of myself. But maybe the occupational therapist is able to say, well, they actually aren't able to stand and walk on their own. So I'm not sure how they would be able to go home and get groceries and take care of themselves without additional help. It's also helpful to get additional information from family, especially when you're thinking about the decision of people living in the community. Are people really understanding their own limitations and where they're at? So somebody could say, I understand that I have some memory problems, I have dementia, but, and I understand that that makes it hard for me to take care of my medicines or to make it to appointments, but I know that my daughter's going to be able to help me with those things, and I'm going to rely on her for that. And I think otherwise I can function in these ways. Or I know that I'm going to hire someone to come and be with me, and they can help me with my limitations. So you're not allowed to have limitations. It's just that you should really be able to understand how your limitations impact you personally. And then this is just a little bit more about the capacity evaluation. I talked a little bit about how medical providers are able to do this, but aren't always comfortable. The other things I think to think about are when we assess capacity. So a lot of times we don't decide to start assessing capacity until someone makes a decision that we disagree with. And so, oh, this person's in the hospital and they're willing to do what we say, which is to go to rehab and then long-term care. Great, they will go and do that. But really, we should be deciding, are people able to make these decisions in general and not waiting until we technically disagree with them. The other thing I think to think about in capacity evaluation is that people have a right to make decisions different than I would make, or what some people consider like quote unquote bad decisions. People can choose whatever they want to choose. I just want to make sure that they understand what they're choosing and that they have reasoning behind why they're choosing it. But I think that often if people aren't making decisions that align with what I would have chosen or my values, then sometimes providers think, oh, they can't make that decision because they're making a different decision than I would. So I think that's a really important context. And then I want to talk a little bit about some tools to try to apply that initial framework. So that Applebaum framework of those 4 components on the last page is kind of the core of capacity evaluation. And then there's some different tools that can help different providers kind of think through different scenarios and if people really have capacity. And so the 3 tools that I really think about are the MedSales, the ACE, which is the Aid to Capacity Evaluation, and then the MACCAT. So the med sales is on, I'll show you an example of that on the next slide. But med sales is often used when we're assessing someone's ability to decide about living independently in the community. And so helps to kind of shift the framework that people often use, which is around medical decision-making and medical decisions, but provide some examples and ways to think about, can someone live in the community? The ACE tool is a tool primarily for only medical decisions. And so is there a medical decision and how can we assess if someone has capacity to make that specific medical decision? And so they go through those same 4 components, but there's 7 different questions, and it really tries to get at ways to ask questions to get at those 4 components and helps kind of guide people through those 4 components. And then the MATCAT is similar, often for medical decision-making, still looks at those same 4 areas, but has kind of some scoring criteria to make it a little bit more quote unquote objective. And the MATCAT was developed mostly to work with people who have schizophrenia or other severe mental health conditions. The limitations that we see in people's cognition is often different in people who have schizophrenia or delusions or paranoia than it is in people who have dementia and memory loss. And so the MATCAT's a good tool that you can use in that specific population. So this is just an example of the med sales. So there's multiple different questions that you can ask the patient, and these are the prompts. With that tool, you choose 3 different prompts from this list. And then on the next page is kind of what you go through for each of those prompts to help you get at those 4 components. I'll kind of go through that with one of these, which is you notice that you have a cut on your foot, it's not healing and it's become infected. And then you kind of go through step by step if people are able to think through it. So step number 1 is just really understanding. You give them the prompt and you say, okay, tell me what the situation is. Can the person repeat back to you the situation that you just explained? And then you ask them to express a choice. Okay, what would you do in this scenario? And you try to get them to express some option. Could be anything. Sometimes people will say, I would ignore it and hope it gets better. I would go to the hospital. I would call my sister who's a nurse to come look at it. I would put a Band-Aid on it. All sorts of decisions. And then you try to understand, like, why are they making that decision? So first you have them express a choice, then you have them do some problem solving of, okay, so why did you choose that? And maybe they said, well, I would never go to the hospital. And you say, okay, well, why is that? Well, last time I was in the hospital, I almost died, and I don't ever want to be in the hospital again. That might be a reasonable decision for that person and their history and their values. The problem solving is often the thing that people have a hard time with. And so that's an area that you can really push people on of, well, what else could you do? What are your other options? What else is there? And so you kind of keep pushing and pushing and pushing until you get to a place where either you say, yeah, they can really think through what are the different options, or you decide, yeah, they really can't, they can tell me the first step, but they really can't tell me farther. So after you have different options, you say, okay, well, what's the difference between these two? What's good about this choice? What's bad about this choice? And then try to have them explain what are the consequences of that. I think commonly people, the consequences is often, well, I could die. People say that all the time. And so really like making sure that they understand how they would die, like what's the worst thing that could happen? I could die is almost always the right answer. But like, do they understand, well, I could die from an infection, or I could eventually lose my leg if the infection gets worse? Are they able to really generate the consequences to that decision when you kind of carry it down each way? So anyway, this is the med sales tool. So you choose 3 of those prompts, and then you go through this process with each one and really just try to make sure that they can express a choice, that they understand the situation, that they can reason through the risks and benefits, and then that they understand how their own situation applies. And so the appreciation piece here comes in with the kind of comparative reasoning part of, like, if they say, well, I'll just take care of it myself. And if they can't tell you, well, how would you get antibiotics, or how would you get, if they can't actually tell you how they would take care of it themselves, then they can't really appreciate how that's applying to them personally. And then just a few kind of best practices in general when evaluating older adults, but especially with a capacity evaluation, you want to make sure people can hear you. Hearing loss is really common. We use what we call a pocket talker, which is a sound amplifier. People just put the earmuffs over their ears. we had a patient that everybody thought had really severe dementia. His wife gave all the history, and then we put a pocket talker on him, and it turns out he could communicate very well his needs and wishes, just he didn't know what was going on because he couldn't hear it. And so really important to make sure that people are able to hear you and understand what you're saying so that you know that they're answering appropriately. Sometimes with hearing loss, you need to ask people to repeat back to you just what the question was to make sure they're actually hearing it, or using a whiteboard where you're writing things out, things like that. You also want to make sure if you're doing any of the assessments that Dr. Bloemen talked about, that people have glasses on, that you're making sure that they have vision correction if possible. And then you want it to be a calm, quiet, safe environment. And so as much as you can have it be close to a home environment as possible, and ensuring that they're either alone or they're with someone that they trust, not with somebody that makes them uncomfortable or feel nervous. The emergency department with, all sorts of alarms going off is probably not the best place to assess capacity. It might be your only option, but really trying to make sure that things are quiet and people can focus and concentrate and there's not distractions. And then just a few other considerations that I think are super important. So one is around language, and that is both like English language speaking versus other languages. If somebody has a history of speaking multiple languages and their English language proficiency is low, even if they can speak English, it's really important to get an interpreter in their primary language or their first language. And then we really think having an in-person interpreter is best and ideal, maybe not always possible. And if an interpreter can be somebody who comes from a similar culture, who can really understand that cultural context, that's super important. And then other things to think about is if people have aphasia, so meaning speaking difficulties. So a lot of times if someone's had a stroke, they have difficulty with expressive aphasia, meaning they really can't get their words out and they can't speak fluently. A good example of this, there was a woman who had reported sexual assault at a nursing home, and she had asked to go to the emergency room, had gone to one emergency room, and they said, she doesn't know what she's talking about. They sent her back. And then she again asked to come to the emergency room, came to our emergency room, and I talked to her. And I mean, it took me probably 2 hours to just get a very basic story about what happened, with lots of patience and lots of creativity around, asking the same questions in multiple ways to make sure that I'm understanding. She wasn't able to say full sentences, so trying to understand what she was saying and then asking yes or no questions for her to confirm, asking that same thing in multiple ways, kind of coming back to that to make sure that she's consistent, to make sure that I'm asking things in ways where she has to say both yes and no to mean the same thing, so that people can't just say yes over and over. But a lot of creativity. But just because someone has expressive aphasia doesn't mean they're not able to understand what's going on or express what they want. It's just a lot more challenging. And so thinking through that and thinking through how to be patient-centered in that way, I think is really important. And then finally, thinking about cultural considerations. So we think about this in terms of like what families find acceptable in terms of care. One case we had was a gentleman who came in, the family had been homeless for decades, and that was really their family's value. They valued being homeless, actually. They felt most comfortable homeless. We offered some resources and they said, this is how we've always lived. We'd prefer to continue to live in our car. That's where we feel comfortable. This is the community we know. These are the people that we know. And so even though that didn't feel like the safest discharge or the discharge that was best to us, that was within that family's values. And so choosing that made sense in that context. We also think about cultural considerations in terms of, like in some cultures, sometimes the oldest son makes decisions for parents as they get older. And so maybe the patient always looks to the oldest son to make the decision. That doesn't mean they're unable to make that decision. It just means that that's how they choose to make decisions in their family and culture. There's also a lot of cultural considerations around healthcare and the distrust of the healthcare system. There's been a lot of inappropriate, the healthcare system has inappropriately treated a lot of groups of people historically, a lot of groups of people. And I think it's very reasonable that people who grew up in a time very recently where their loved ones and people around them and their family and their friends were treated poorly by the healthcare system. Of course, you're not going to trust me when you come in and see me. And I think it's important to recognize that that's a part of what's going on. And so just really thinking, where does this person come from? where is this person's family's values and why is it that way? And how is that impacting the decisions they're making? I don't want to decide someone doesn't have ability to make decisions just because their framework for thinking through decisions is different than mine, because we come from very different places. The other thing that we often do is we talk as a group around capacity to try to make sure as much as possible we're decreasing our biases. And so with these cultural considerations, we say, well, they're thinking through this and why would that be? And can you think through that? And I think the more you're able to talk to colleagues and other people, sometimes they're able to see things that maybe you wouldn't understand yourself. All right. And I'll pass it back off to Dr. Bloemen to talk a little bit more about cognitive impairment.
So I think there's some core diagnoses that we think about when we're talking about cognitive impairment, and then capacity as an extension of that. So I think the most familiar is dementia. There's a bunch of different types of dementia. We'll go through kind of the most common ones today, but please feel free to ask if there's any ones that you want more explanation or you've heard of other things. So I think people are most familiar with Alzheimer's and vascular dementia. And there's even debate in the literature about how much of Alzheimer's is a vascular disease. I won't get into that because that gets very heady very quickly. Those two diseases both present typically with memory impairment first, and then behaviors later on, or delusions, paranoia later on can develop or often don't develop for other patients. There's a word finding difficulty that like dominant form of Alzheimer's. So some people present with more short-term memory. Some people present more with word finding difficulty early on, but both of those tend to come earlier in the disease before the behaviors that come with dementia. So those are kind of the stereotypical ones, what we see on TV, what we see in movies. Then there are the Parkinson's disease spectrum disorders. And so these are going to be particularly dominant in our veteran populations because Agent Orange is associated with all of these, and patients can get services through the VA for these, which I think just kind of got passed with the PACT Act. So I just wanted to mention it if anyone is taking care of someone like that. That's another option for care. Parkinsonism is a motor disorder characterized by stiff movements, slowed movements, and some other signs on physical exam. And each of those are associated with a dementia. So idiopathic, or what we call just Parkinson's disease, develops dementia much later on. Dementia with Lewy bodies is probably what we see the most in the elder mistreatment world. And that one often presents with hallucinations and sleep disturbance, something called REM sleep disorder, where people are acting out physically their dreams, which in our veteran population can get very dangerous if they're acting out one of their PTSD nightmares, which we see not infrequently, before they get the memory impairment and before they get the motor impairment. And so it's a little bit of a flipped diagnosis. So often with Lewy body, the hallucinations are out of the corner of the eye. They're small children or furry animals, if we're lucky, and they have the nice version of the hallucinations, but some people do have hallucinations of people in their house, especially our vets or people with traumatic pasts. They can have very violent hallucinations as well. And also have fixed delusions with that disorder of people trying to get in or threatening them in some way. And then there's a few other rare forms of Parkinson's that are rapidly progressive, multi-systems atrophy and primary supranuclear palsy that are also associated with dementia, but those are kind of in the Parkinson's disease bucket. Frontotemporal dementia is also a different kind of flavor. It usually hits our younger population, so more in the 40s, 50s, maybe early 60s, but it's typically a younger onset. And that one primarily impacts the frontal lobe first. And so the frontal lobe is the brakes on our brain. It tells us not to eat that sixth cookie or not to drive 100 miles an hour down the road. And so what you see with this particular disease process is a loss of inhibition and a lot of executive dysfunction. This disease can be really difficult to diagnose and actually was first described in state insane asylums back in like the 60s and 70s because these patients were admitted for psychosis or for criminal behavior related to this process, and then developed dementia a couple years later, and developed more of that classic symptom. So this is a really challenging patient population to take care of. They can often be very physically aggressive, sexually aggressive, and they're younger and more fit. So they're able to physically do more damage when they are acting out. And so it's a particularly challenging disease process to treat. Notably, also, the patients that have this have memory intact. So they remember what they did, but they usually have no remorse and no insight into this being a behavior change for them. So it can be a particularly isolating disorder as well, not just to the patient, but to their family. So it's one of our, I think, more heartbreaking versions of dementia, if I can, not that they're not all bad, but it's one that's very particularly challenging. And then alcohol and other substances are directly toxic to the brain. And so you can have different versions of alcohol-induced dementia. So there is alcohol dementia from years of chronic alcohol use that has just become toxic. It's not related to intoxication currently. Sometimes this can develop after people have been sober for a long time, like 10 years. And then it's just been that cumulative damage over their life course that has resulted in an alcoholic dementia. There are other versions called Wernicke's or Korsakoff syndrome that can be, they're very particular and they're related more to the nutritional deprivation that our chronic alcoholics see. But alcohol dementia is a form that you will often see in our patient population. And then there are other rarer forms of dementia as well, like Creutzfeldt-Jakob and HIV dementia and others that I'm happy to talk about if anyone has any particular questions about those. But those are kind of our core dementias. Staging of dementia is also, I think, particularly helpful. So the fast stage, I like pretty well. It's pretty commonly used in clinical practice. And it goes through kind of from normal aging to severe dementia. And I think it's really helpful to talk about where our patients are in terms of their fast staging, because dementia can be a really variable process. And this is what I mean, as a geriatrician, why we love it is because it's all about function. What can they do for themselves? Where are they on this progression? 7A with severe dementia, so only speaking a few words during the day, that's your hospice designation for dementia alone. There's other ways to get into hospice, but that's when we start to think about really end of life. In the 6A range, you're looking at the last couple of years of life. And at 6A, you're probably not going to have capacity, but you could still do a formal capacity evaluation, but that's when we start to see pretty severe decline. And then other diagnoses that we think about are those primary psychiatric disorders. It's a wonderful development that people with schizophrenia are now aging into their 70s and 80s. They're doing well, but that can start to impact decision-making as well. And then other forms of psychiatric illness that can present either in earlier life and people have thankfully aged with them, or there are some rare developments of psychiatric disorders later in life. And the capacity evaluation for that is a little bit different than what you would do for someone with dementia, because usually the memory is not the issue, it's more the reasoning. Traumatic brain injury is also very tricky. We see a lot of TBI, especially again in our veteran population, but also in our general population, that can impact decision-making. And I have found that these people are very tricky because they look really good, or they can look really good at first blush. And then when you get into them, get to know them and see them over time, you can see that there is a big deficit. And often I think this one in particular is most helpful for providers who've known the patient for a long time to weigh in on capacity. And then stroke, like we talked about before, some strokes can directly impact the temporal lobe and the areas that impact memory and thinking. But then that aphasia, both being able to express your words, but then some people have different types of what we call receptive aphasia. So they can't either understand words auditorily, and so you need to write them down, or vice versa. They can only understand verbal language and not written language. And so those would not be cognitive impairment. It's just how the brain needs the input has changed after this insult. Those are kind of the core long-standing chronic illnesses that impact cognitive function. The other things that we like to think about, and especially before we do a capacity evaluation, is we want to make sure people are not delirious. So delirium is a large field of study in medicine. It's it's an acute change in mental status, so something that's happened over a few days or a couple of weeks. And there's always a cause for it. And so people with dementia are at increased risk of developing delirium. But it's usually from like an acute illness, pain, dehydration, certain medications. Benadryl is like the bane of every geriatrician's existence, can cause delirium. Constipation can cause delirium, and in our older adults, we see this not infrequently, and it's not something people think about, but is actually a really big player. And then just being in the hospital or being in a new environment can also precipitate delirium. And so when we're assessing people, both for a cognitive evaluation and especially for a capacity evaluation, we want to make sure that they are not delirious and that all of these things have been eliminated before we assess them to give them their best shot. Severe depression is one of the so-called mimics of dementia. It's very challenging because depression is also an early sign of dementia and withdrawing from your social circles as your brain is no longer functioning the way it used to. Treating depression can help improve function though. So I had a patient who presented to me last fall, and he was profoundly depressed, also has mild dementia, and his functional status got a little bit better when we treated his depression. He still has dementia, he still needs help, but he was able to be left alone, for example, once we got his depression under control. And so it's also something that we think a lot about in our clinical practice and wanting to address and link people to resources for that. Of course, acute intoxication is something that we want to reverse. Older adults tend to hang on to substances longer in their system. It just takes longer to clear. So making sure that we're giving adequate time to clear anything that might be in there. And then B12 deficiency and hypothyroidism are something that doctors should be screening for. Those can both impact your cognition pretty profoundly. And so making sure that their vitamin B12 is normal and that their thyroid is within the appropriate range for their age. So when we are approached for capacity evaluation, we find it's much more helpful, instead of just saying, hey, we need a capacity evaluation, is really to have a conversation with whoever's requesting that, whether that be APS or law enforcement or another medical provider even, to say, well, what's the question you need answered? Do you need us to know, can they assign a decision maker, make medical decisions, make financial decisions, remain living in the community, have this particular person remain in their life? What is the question there? And then saying, like, do you feel comfortable assessing for that question? Because some people will say, no, I don't assess for financial decision making that often. I don't feel comfortable, but my colleague might, and let me reach out to them. And so that, I think, having that dialogue and that back and forth is particularly helpful. And then we have run into, not infrequently, the courts or other organizations like need an MMSE or need a MOCA to check like that box. And it's really helpful for us if people just tell us, hey, like, I'm going to need this because it's part of our process. Because we often will push back because doing one of those evaluations doesn't actually help my clinical assessment of the patient and can really derail it. For example, I had a patient I was doing a capacity evaluation on, and then they really wanted me to do an MMSD for the court. And then he just like started peeing in the middle of it, started folding the paper into like one of those little fortune teller things that little kids play with. And it really derailed our conversation. And so, I think that's partly why, if you're getting pushback from providers of not wanting to do those things, it's because it's not necessarily helping us diagnostically and can derail the assessment. So it's helpful for us to know why you're asking for certain things.
Sorry, hi. So what to consider when a person lacks capacity? Do they have an MDPOA? Do they have family or other supports in their life? Do we need to do a proxy process to designate a decision maker? And as Dr. Tietz mentioned earlier in the conversation, maybe they still have the decisional capacity to designate an MDPOA, despite lacking decisional capacity around like discharge planning or medical decision making, for example, because that is a less complex decision. And having patient buy-in to decisions being made on their behalf is so important. It's important for the patient's well-being. People are likely to be more successful if they feel that they've played a part in the decision-making process. So just being able to still include patients patients in conversations and get their feedback and explain some of the, decision-making, process with them, I think is super valuable. Looking for the least restrictive options is considered best practice. Usually, that may mean trying to make adjustments and changes at home to allow patients to return home. There are a lot of things we can do to make home more safe or to reduce harm. And pursuing guardianship is always considered the last resort option. So in the work we do in elder maltreatment, we get this question a lot. The question may be, is if the MDPOA is a suspected abuser, can they continue to be the MDPOA? And I think these questions, in many situations, are incredibly helpful. Are the decisions in direct conflict with what the person's previously stated wishes were? Are the decisions harming the person's well-being? Is the POA not acting in the person's best interests? Is there a financial motivation for decision-making? Just because there may be abuse or neglect does not mean that the decision maker does not care about this patient. This is a very complex relationship. Many times we see that, these folks can make great decisions for their loved ones despite despite other existing concerns. So again, going back through these questions, really having a conversation about it is important. Okay, it looks like we have to skip the case study and go straight to questions. So I'll go ahead and, and quickly our resources. We talked about some of these tools, the last three, and then this resource guide is a great guide to look at as well.
Yeah. While we're waiting for questions, Sarah, potentially you could share that case study and we just won't do the poll. We probably have time for that, but we are short on time. So if people have burning questions, let us know. We'll start with those.
Sounds good. So there's a patient that has stated for decades that he never wanted to live in a nursing home, even if it put him at risk for harm or death. The patient had lost capacity due to a dementia diagnosis, and his granddaughter was his designated decision maker. The granddaughter really wanted to respect his wishes in her decision.
Oh, you muted yourself.
I don't know what happened, sorry. The granddaughter worked hard to respect his wishes and keep him at home. Ways that she reduced harm were to increase home care at home, increase regular family check-ins at home. He was living at home alone. The patient actually had stated that one of his favorite pastimes was doing home chores. He talked about using power tools and climbing ladders to clean out gutters. So there was an effort to remove those power tools from the home, remove all the ladders. There's still risk at him being at home. He was a fall risk, of course, but of course he'd stated that he wished to stay at home despite the risks. And at the time that he was able to communicate those wishes, he was clear that he would like to do it despite, harm or death.
Yeah, I think we talk a lot about kind of two principles there. One is the dignity of risk. And so allowing people the dignity of risk sometimes, even when they lose capacity, I think it's such a fine line of balancing safety and patient autonomy and what their values were before. And so obviously this is always a complex conversation with families. But we talk a lot about the dignity of risk. And then we also talk about harm reduction instead of safety. And so there's never a perfectly safe option, right? Being in the hospital isn't safe either. There's all sorts of infections and risk of delirium and falls. And so we think about kind of those two things are principles we try to think about when we're making some of these decisions.
So one of the questions in the chat is, how do you respond to people who refuse to engage with an assessment, either by remaining silent or acting out?
Go ahead, Elizabeth.
Yeah, so I mean, we have some advantages of like someone's already gotten them to our office or to the hospital, which is helpful. Usually, this happens in the hospital, also not infrequently, and trying to just align with them and saying like, I'm trying to get you what you want and like what your wishes are, but we gotta like make sure that we're all on the same page and understanding things. And I think, the more you can align with the patient and spend time with them, it does take time to just build that rapport, the better. I think we also have advantages as geriatricians, is I can come in and just say like, hey, I'm a doctor who only takes care of older adults. I'm not a psychiatrist or a neurologist, where people have kind of preconceived notions around that, of what that means. But I think it's a lot of just trying to align with them as much as possible, which I know is much easier said than done.
Yeah, I think we also, when people want to leave the hospital against medical advice, we have to assess capacity in those situations. And so Elizabeth is maybe nicer than me, but in those situations, I'll just say like, hey, I can't let you leave unless you talk to me. Like, you just got to be like, open and upfront. Like, I can't let you leave. So like, can we sit down and just have this conversation and get it over with and try to make it as painless as possible? But sometimes you can take time to align, and sometimes you just have to say like, all right, well, if you can't have a conversation with me, then you can't leave. And that doesn't always go well, but I think Elizabeth's or Dr. Bloemen's approaches are better. But if push comes to shove, sometimes you just got to do that.
That's like another question. Do we use the same capacity tool for dementia patients as people with mental health diagnoses? I think our tool is often determined by what the decision is. And so we'll often start at the same place. If people have severe mental health diagnoses, often that's when we will bring in more of our psychiatry colleagues or try to do things together with them. But the exact tool is usually the same. It's more just getting a different lens. Dr. Tietz, do you have any thoughts?
I do like for people with mental health diagnoses that MATCAT tool. I think that's helpful. It's the same framework, but it's a different way of kind of going through questions. And a lot of times with mental health diagnoses or with people with traumatic brain injury, when it's not primary memory impairment, it's a lot more complicated. And so sometimes that means just multiple assessments by multiple providers and then kind of coming together to see what different people think. And so sometimes it can be a single assessment and sometimes it ends up being multiple.
All right, we've got about a minute left. I'll be dropping an evaluation in the chat. And I believe on the next slide, there is some contact information. I know some questions might arise as you're, thinking over the content that we covered. And let's give a huge thank you to our three wonderful presenters. This is a great webinar. You're getting lots of love in the chat. And thank you all for attending, spending an hour with us, really diving into some important content.